Hi, and welcome to our webinar today, hosted by the Big Hospital SBIRT Initiative as a part of our monthly webinar series. The topic today for our webinar is marijuana SBIRT. And I will be your facilitator today. I'm Tracy McPherson. I'm one of the co-leads of the BIG initiative, both the Big Hospital SBIRT initiative and the BIG EAP initiative. I am at NORC at the University of Chicago and provided my contact information here for you should you want to contact me following the webinar. If you have any additional questions we may not be able to get to today and that you'd like to get some additional information about what is discussed today in our webinar, and if you'd like to learn more about the National ATTC work and the BIG Initiatives work that is ongoing, which is very much focused on integrating SBIRT and sustaining SBIRT practice in a variety of medical and behavioral health care settings. So welcome everyone, and don't hesitate to contact me if I can assist you in any way following the webinar. This webinar is hosted and sponsored by the National Screening, Brief Intervention, and Referral to Treatment, ATTC. The easiest web address for me to give you to remember, there are multiple ways to get to the ATTC website, but the easiest one is ireta.org/ATTC. That's IRETA.org/ATTC. And we have additional links available at the end for you, and we'll be also including additional links as needed along the way in the chat feature. But we really encourage you to take a look at the National SBIRT ATTC website. Webinars that we've done previously and going forward are archived and saved there for your benefit. There are lots of resources to help you implement SBIRT in your organizations, and so I hope you will think of us as a sort of a one-stop shop place for all the resources that you need in your own organizations. Just a couple housekeeping items. We hope that we'll have the opportunity to offer moments for you to ask questions. We have a lot of terrific, rich information to share with you today. If for some reason we're not able to get to all of the questions, we still encourage you to go ahead and ask questions using the chat feature in your control panel that's along the right. You can simply type in your question, and it records them, so if we can't get to them, perhaps we can get those addressed later. But it will be saved, so if we don't get to it, you can also feel free to email me and see if I can help facilitate getting an answer to your question. Another housekeeping item for you, we will be offering certificates of completion today following the webinar and continuing education. This is going to be available through the National SBIRT ATTC, or IRETA, and IRETA will be following up with you by email for those who have attended with information about how to obtain that certificate and the continuing education credits. Also, following the webinar, you're going to receive a very important evaluation form. So I can't stress enough that it's extremely important that we engage you in giving us your feedback for us to be able to bring you future webinars and the kind of quality webinars we're giving you today. We need to hear from you and get your feedback, and that evaluation form will be coming via an email link at the end. So please, please, please complete that for us. It's really critical to sustaining the work that we do. And it is certainly my pleasure today to welcome you to this webinar and our speaker to hear Dr. Paul Seal talk about marijuana SBIRT and reducing drug-related morbidity and mortality in primary care. We are thrilled to have Dr. Seal. Dr. Seal is a professor and director of research in the Department of Family Medicine, Medical Center of Central Georgia, and Mercer University School of Medicine. Dr. Seal has been involved in teaching and research related to substance abuse for more than 2 decades in both the U.S. and abroad. Since returning from South America in 2000, he has been very active in substance abuse research, training health professionals to perform alcohol screening and brief intervention. and facilitating implementation of SBI in clinical settings. Dr. Seal's first pilot study trained faculty and residents and implemented alcohol SBI at Mercer University's Family Medicine Residency Clinic in 2002 through 2003. The successful pilot led to his role as PI of the Georgia-Texas Improving Brief Intervention Project, which is funded through an NIH R25 project, which trained faculty and residents and implemented alcohol SBI in 8 family medicine residency programs in Georgia and Texas. In 2007, he served as the co-author of Georgia Basics. I know many people have heard of the Basics training, so we very much appreciate his contribution to the Georgia Basics program, a state SBIRT proposal to expand the training and service delivery to include SBI for alcohol and drugs in Atlanta and in Macon. Since funding of the Georgia Basics in 2008, he has served as the SBIRT Medical Director at the Medical Center of Central Georgia, which is Georgia's second largest hospital. He has developed and implemented plans for providing SBIRT services in hospital emergency departments, inpatient floors, urgent care clinics, and selected outpatient clinics. Since 2009, he has served as the PI of the Southeast Consortium on Substance Abuse Training, a SAMHSA-funded residency SBIRT initiative focused on disseminating SBIRT training and implementation in primary care residency programs and private practices in Georgia, North Carolina, and South Carolina. So please join me in welcoming Dr. Paul Seal.
Thank you very much, Tracy. It's my pleasure to be with you today, and I look forward to seeing the questions and getting some of the feedback from our listeners today. I understand we have a interdisciplinary audience that includes medical providers, mental health providers, substance abuse providers. And I'll say from the beginning 2 things. Number one, I speak as a family physician, and my primary obligations are in primary care. So you'll probably see that orientation in the things that I present. The other thing I'd like to say as I begin is that I think marijuana research is an evolving area, and we've done our best to put together a module that summarizes the current evidence about medical effects of marijuana and brief intervention and referral to treatment related to marijuana. But it is a changing field, and I anticipate there will be some changes in this area over the next 5 to 10 years. So I think it's important to watch the literature as we gain more and more information, especially with the dissemination of medical marijuana. Today, let's see, Tracy, can you move the slide for me? I can't seem to get it to move forward. My objectives today are to define SBIRT, which most of you will be familiar with, define drug abuse, which most of you will also know well, and then outline the screening protocols, introduce the DAST 10 for those of you who don't know that. I start with then a discussion of the medical and other effects of marijuana use, and then we talk about the efficacy of using motivational interviewing with patients who use marijuana. What is SBIRT? Begins with screening, which is a quick assessment of the severity of substance use and an attempt to identify the appropriate level of treatment. Brief intervention, which involves increasing insight and awareness regarding substance use and trying to enhance motivation toward behavior change. And finally, referral to treatment is providing those who need more intensive treatment with access to specialty care. And that's the lens through which this presentation will be presented. Drug abuse, in our context, has to do with identifying people who are at risk because they use marijuana, or high risk because they're frequent users, have some significant complications, and may be dependent on marijuana. Some of the consequences may have happened related to substance abuse, or some may simply be likely to occur if that use continues at the same level or increases. So our SBIRT process really goes from very low use to very high use of marijuana. We have used in most of the clinical settings that we are involved in 5 basic components in an SBIRT system. We try to start with a pre-screen. We use single question pre-screens for drugs in our clinical settings. If that single question pre-screen is positive, then we use the DAST-10 to get more information about people's use and its consequences. We then do a clinical intervention in our setting. A lot of those are done by physicians or resident physicians. In many settings, those are done by other healthcare professionals, might be nurses, social workers, or other professionals. If you're in a behavioral science arena, it might be any of a number of levels of behavioral science professionals. Referral as appropriate for patients with the highest levels of risk. And for all of these patients, we really emphasize follow-up, that patients be reassessed, and the concepts that are talked about in an initial brief intervention be reinforced at future visits. So let me take you through those steps one by one. We begin with a pre-screen. In our clinical settings, we encourage the screening of patients every 6 to 12 months. And we use a validated single question about drug use, and you'll see that slide coming up soon. In our setting, questions asked by the nurse or the nursing triage personnel. In some places, it may actually be asked electronically through an electronic medical record. But the question that we ask, this is a validated question from Smith and colleagues in New York, is how many times in the past year have you used an illegal drug or used a prescription medication for non-medical reasons? And if the patient reports that they've used drugs one or more times in the past year, then that's considered a positive pre-screen, and we move on to then have the patient complete the DAST. I'll just pause briefly there to say that this is the only validated single question pre-screen that we're aware of at this point. We're in the process of doing a validation of a couple of modifications on this question. Some people don't like the use of the word illegal drug, thinking that that's going to cause many people to not want to disclose their drug use. So maybe we could use words like recreational drug or street drug. Other issues, sometimes people don't understand what you mean by a non-medical reason, but in general that's meant taking the medication in a way that it was not prescribed to be taken. The second step after finding that a patient uses drugs to some extent, to some degree, is to administer the DAST. And so the patient in our setting usually gets a paper form. It's a 10-question form. They complete the DAST and give it back to either to the nurse or the person who gave it to them, or in our setting, a lot of times they'll give it directly to the clinician. And then the clinician will perform a brief intervention, and we actually teach a couple of brief interventions depending on the patient's level of use and the level of consequences. So based on the score that the clinician chooses which of those two brief interventions to perform. This is the DAST-10. The DAST was originally developed in a longer form and then shortened to a 10-question instrument that we find pretty efficient and very easy to use in the primary care setting. If you're in a behavioral health setting, you may want to use a much more in-depth instrument than this, but we find this is very simple and easy to use and pretty time efficient in primary care. So you can see the questions, unfortunately, they should have been numbered 1 through 10. Something happened in the translation here, but have you used drugs other than those required for medical reasons? You abused more than one drug at a time, identified medical problems as a result of your drug use, had blackouts or flashbacks, ever feel bad or guilty about your use, does your spouse or parent ever complain about your involvement with drugs? Have you neglected your family because of your drugs, engaged in illegal activities, experienced withdrawal symptoms? And one of the most important things, I think, the last one, are you always able to stop using drugs when you want to? So the patient obviously gets a score then that's going to vary anywhere from 0 to 10 on the DAST-10. Just a comment or two about the DAST. I know a lot of us wish we had some stronger validation information for this instrument, or even a better instrument. We like the DAST because it's brief and efficient. It was developed in 1982. It can be self-administered in about 2 minutes and scored in less than a minute. Again, we use 10 of the original 28 IAMs on the full scale. The validation data, unfortunately, are fairly limited. There are 2 studies in the U.S., 1 in India, and most of them involve psychiatric patients. So if that's the arena you work in, we have pretty good data for that. We don't really have good data for primary care. But the DAST in those settings where it was studied has exhibited valid psychometric properties, and it's been a pretty sensitive screening instrument for the abuse of drugs other than alcohol. Again, advantages, it's a short instrument. It can be self-administered. There are some projects going on now to create, to utilize electronic screening for instruments like the DAST and the Assist. Some of the disadvantages of this instrument, it is not drug-specific. So if you've used, for example, a longer instrument like the Assist would allow you to use the form, that particular assessment approach for every different drug that the patient uses, and people get a risk score for each substance. This is not drug-specific. Again, the validation data are limited. Doesn't really distinguish between active and inactive illicit drug use. So someone who's been in recovery for even many years would still have a positive DAST. And it's a bit focused on dependence, so it may not be a super sensitive instrument to use in people who are very early in recreational or experimental use. These are the risk zones that we use in our setting, and I have to say that the line between at-risk and high risk for us is a little bit fluid. We took the cutoff scores from Maisto et al. You can see the reference there at the bottom, and they felt like the sensitivity and specificity in discriminating drug use disorders were optimized with a score of greater than or equal to 3. But I don't think that's a really firm, hard number. It has not been for us in the clinical arena. But again, once you get to scores of 3 or more, you're talking with people who have some significant consequences or much higher risk, and those are the people that you should think more about connecting to other research sources or referring to higher levels of treatment. I'll talk a little bit more about that as we get through the presentation. In our setting then, whoever's administered and going to do the brief interventions notes the items that are marked on the questionnaire, calculates the score. And then we always ask our clinicians to obtain and document a recent alcohol and drug use history. The reason for that being that if you use a system like we use, then some of the answers may be given on a paper form. Some of them may be given to, for example, you may have a questionnaire that's distributed by a receptionist or a nursing intake person. We find as people progress through the clinical encounter, their level of trust tends to increase. And so we have about a 10 to 15% difference in the responses that we get to questions if the clinician asks them again. What we hope, and it does happen fairly frequently, is if you have a good trust relationship with your patient, they may actually disclose higher levels of use or more use than they did on paper questionnaires. On the other hand, we do have some patients who are comfortable with a paper instrument. It's pretty anonymous. It's not very threatening. They may admit to some use, and then when the clinician asks them about their alcohol or drug use, suddenly they say, oh no, there must be some mistake. You must have someone else's paper. So they get a little bit fearful or embarrassed or spooked in the interview. And so we've had to learn to live with that kind of discordant information. But we also feel like the clinician obtaining a recent alcohol and drug history gets us well-oriented as clinicians as we move into a brief intervention. We have some details of use and gives us a chance to explore issues we might want to explore related to that alcohol or drug use, and to hopefully build and enhance the doctor or clinician-patient relationship. Step number 2 is intervention, and we have linked for you an intervention card. I'll show it to you here, but if during the presentation or after you want to click on it and print it and use it, you're welcome to do that. I want to acknowledge my collaborators for this presentation and for all of our training projects. I work with Dr. Sylvia Schellingberger, who's our Director of Behavioral Science in our department and our residency program, who has more than 30 years of experience teaching in this area. Also, Denise Crow-Clark, MFT, who's been our project director in our current CSAT project, and she's done just tremendous work developing a lot of the visual things that you'll see and some of these clinical aids, and we've gotten very positive feedback on the intervention card. We modeled our card after a similar intervention card that we saw from the Oregon Health Sciences University residency SBIRT project. I understand that they may have borrowed that from the folks at Yale and their SBIRT project, and from before that, I can't give you all the references, but we at least want to acknowledge those who have shared with us. So this is a kind of a handy guide for our clinicians. It reminds them, as we do alcohol interventions, what a standard drink is. It's got the single questions there right in the middle at the top. It's got the scores for the different risk levels, and then on the right side, lower risk drinking limits for if you're doing alcohol interventions. On the other side of the card, looks like my format has unfortunately kind of scrambled here. Hopefully, if you link to the actual card itself, it'll be a little bit clearer. We're going to take you through all of the 6 steps that we teach as a way to approach an MI-based brief intervention, and those are the bold topics on the left that start with ask permission, provide feedback, and so forth. And so it gives you the different zones. As you can see, the zone 1, the lower risk, a person with a DAST score of 1 or 2. Zone 2 is a person with a higher DAST score of 3 or more. And some information about all of our learning materials are available on the web at www.sbirtonline.org. So I'm going to sort of take a break then from the SBIRT protocol and begin to take you through the medical part. I know this has been very important for our physician learners, and I would guess that this is a huge issue in many of our areas, especially as medical marijuana is becoming more and more widely used in the United States. So this is a summary of what marijuana is and the good, bad, and the ugly of marijuana. Marijuana is basically dry, shredded green and brown mix of flower, stem, seeds, and leaves from the plant Cannabis sativa. Its main active ingredient is delta-9 tetrahydrocannabinol, or well, we use the letters THC through the rest of the presentation. And important to know that there's been a gradual increase in the THC content over the past 2 decades, that the developers and sellers of marijuana have been working to increase THC, which is the psychoactive component. Want to just briefly mention that there is a similar product out there called K2 or Spice, and we don't have a lot of this in central Georgia, so I can't speak to it too much. Probably others would know a lot more about that than I would, but synthetic marijuana is an herbal drug mixture that usually contains some designer chemicals that fall in the cannabinoid family. And they have been scheduled as illegal by the DEA starting in March of 2011, but they're fairly widely available and widely used. Marijuana can be smoked as a cigarette or joint. It can be smoked in a cigar that's been emptied of tobacco and refilled with a mix of tobacco and marijuana, and what's commonly known as a blunt. That's your right side picture. It can be smoked in a water pipe, so that's the bottom right-hand corner. That cools the hot smoke and decreases the loss of side stream smoke. You wouldn't want to lose any of that. You want the full psychoactive effect. So a water pipe, a bowl, smokers usually inhale and hold their breath to increase the absorption. And just a little humor there for all of us to think about children who've been told always to stay away from drugs, and then Mom serves them the pot pie for dinner. And I'll skip the jokes about the marijuana brownies. So the epidemiology of use, this is clearly the most commonly abused illicit drug in the United States. Lifetime use by 44% of males, 35% of females, and I think we may well see those numbers increase as we have more and more medical marijuana approved across the country. It's the second most common reason for drug treatment admissions in the U.S. Opioids are first, and marijuana is second, and that's been a stop and think for a lot of people. And probably some of you out there thinking, I thought marijuana was not addictive, and what are we doing putting people on treatment? Many of these treatment admissions are children and adolescents. So if you're found to be using marijuana as a teen, adolescent, then many kids end up in treatment because they're using an illegal drug, and not necessarily because they're showing signs of dependence. Highest use is in the younger age group, 18 to 24-year-olds, and the male-female ratio greater than 3 to 1. Epidemiology, In 2009, the National Survey of Drug Use and Health found that 16.7 Americans aged 12 and older reported using marijuana in the last 30 days. The use increased every year from 2002 to 2008. There was a little bit of plateauing, but in general, there's still a huge amount of use, 18% of 18 to 25-year-olds and 7% of 12 to 17-year-olds. So those are the latest figures that we had available when we put this PowerPoint together. A lot of use among high school students, 8th graders 12 to 13%, 10th graders 29%, 12th graders 36%. So a third of high schoolers out there surveyed by the Monitoring of the Future study in 2001 had tried marijuana. And one of the concerning things for many of us that the rates of perceived risk and disapproval of use have declined over the past 3 to 5 years. So again, good likelihood that we'll see these numbers continuing to increase. Pharmacology, I think, is important to understand. There are two different kinds of cannabinoid receptors. The CB1 receptor is highly expressed in the basal ganglia, hippocampus, and the other brain regions that you see there, and this is responsible for most of the CNS effects. So the psychoactive stuff and the high and the other reasons that people would use marijuana for recreational purposes, those are the CB1 receptors. The CB2 receptors are different. They're expressed on cells in the immune system and in bone, and pretty low levels in the central nervous system. And so there's not many psychoactive effects. If you have a marijuana product or a drug that targets CB2 receptors, it's not going to have many psychoactive effects, but it will decrease your macrophage function in your immune system. Cannabinoid effects, if you smoke marijuana and you inhale and hold your breath, then you begin to experience euphoria, relaxation, slowed time perception, altered sensory perception, increased awareness of your environment, as well as hunger. All right, let me try this. Tracy, I'm stuck. Can you move the slide forward for me, please?
I just did, Dr. Steele. You're able to see the next slide?
I am not able to see the next slide. Are you?
I am. Give me just a moment, please. Can you tell me a bit about what you're experiencing? Is it just stuck on the previous slide?
It's stuck on cannabinoid effects, the one with the yellow sign in the upper right corner.
I apologize, everyone. Let me just troubleshoot this just for a moment.
I'll keep talking while Tracy's working to get the slide. The next slide talks about some of the less desirable effects, and I think these are issues that we can talk about with patients to provide them some education about some of the downsides, the not-so-good effects from cannabinoids. Occasionally you can get panic, anxiety, nausea, and dizziness. You get impaired perceptual motor coordination and motor performance. So marijuana is the second most common cause of, there we go, driving under the influence after alcohol. It decreases our reaction time and our information processing. So there's some minor impairment at driving. Not huge amounts have been documented in the scientific studies, and it doesn't correlate well with THC serum levels. So we're not going to probably have people arrested because they have certain THC levels that impair their driving. There is difficulty with thinking and problem solving and learning and memory. So I think those are really key issues for teens and adolescents and young adults who may be trying to get their high school diplomas, college diplomas, and compete in the workforce. That marijuana interferes with all of those things, as well as decreases integration of complex information. And unfortunately, those deficits extend beyond the period of acute intoxication. So potential effects that could affect performance on the job, performance in school, and people's long-term job possibilities. We focus a fair amount with our brief interventions on mental health effects. Marijuana use, paradoxically for many people, is associated with higher rates of anxiety, depression, and schizophrenia. And young age at first use and chronic use have stronger associations with these mental health effects. The strongest evidence links marijuana and schizophrenia, but there's been a lot of written about it, whether this is a causal effect or an association. And right now, the evidence seems to point in the way of an association. These may be people that were predisposed to schizophrenia or other similar symptoms of thought disorder. But if you use marijuana and you're so predisposed, you're likely to see earlier onset of schizophrenic symptoms, worse symptoms, and poorer prognosis. Marijuana can, in fact, precipitate an acute psychotic reaction and may trigger onset or relapse of schizophrenia in those, again, who are so predisposed. Some of the medical effects, you get red eyes, conjunctival injection, and small pupils. You get tachycardia. Orthostatic hypotension simply means that the blood pressure drops if you stand up quickly. You may get dry mouth, some poor motor coordination, some head jerks, and some impairment of smooth pursuit eye movements. Pulmonary effects are probably the greatest physical health effect. You get daily cough and sputum production if you're a daily user, an increase in airway resistance and inflammation, especially in the large airways. More frequent respiratory infections. You'll remember that the cannabinoids affect the immune system, so they decrease your resistance to respiratory infections, and you're more likely to get a respiratory infection if you're a regular smoker. So the studies do show more health problems and more missed work days than non-smokers, especially related to respiratory illness. There are 50 to 70% more carcinogenic hydrocarbons in marijuana than in tobacco smoke, but we'll talk a little bit more through the presentation about the fact that that has not been reflected in higher cancer rates. And so although we could see that evidence in the future, those of us that lived through the 60s and beyond sort of look back and say there's been a lot of marijuana use over the last 40 to 50 years, and it would seem if there were a significant carcinogenic risk, we would have some clear evidence of that by now, and there is not that kind of clear evidence. There is epithelial dysplasia, but no clear increase in cancers of the lung, respiratory tract, or digestive tract. Cardiac effect, you see some famous users there on the right side of your screen. Interesting that marijuana increases your heart rate 20 to 100% shortly after smoking. This lasts for up to 3 hours. It can precipitate some different kinds of arrhythmias, atrial fibrillation, and other fast or speedy arrhythmias. Again, it can cause your blood pressure to drop if you stand up quickly. But there is an almost 5 times higher risk of heart attack in the first hour after smoking marijuana, and that's cause for concern as marijuana-using baby boomers are entering the geriatric age group. Not as big a risk in the early adolescent user. There's also some recent evidence, I don't think it's on the slides, but of a link between marijuana use and increased risk of stroke. So it's a fairly new findings come out in the last 12 months to be aware of and talk with your patients about. Other organ system effects, you have GI effects. It contributes to the development of fatty liver, which can progress to fibrosis and cirrhosis. It slows your liver's ability to metabolize many drugs. And you can get a syndrome known as cannabinoid hyperemesis, people who get recurrent nausea, vomiting, and abdominal pain just due to the use of marijuana. And in fact, in our clinic, we've had an older female patient with an eating disorder who was dependent on marijuana, and she was unable to make progress with her eating disorder because she experienced the syndrome of nausea, vomiting, and abdominal pain. There are some endocrine effects as well, effects on the pituitary. It inhibits the production of luteinizing hormone, or LH, prolactin and growth hormone, and alters the activation of the ACTH and cortisol pathway. Reproductive effects, you can get galactorrhea, that's discharge of milk from the breast, and low birth weight infants. So very important, again, for women of childbearing age to know that this is not a safe drug to use in pregnancy. In fact, premature births and low birth weight are one of the largest causes of pregnancy-related complications, morbidity, and mortality at this time. There are social consequences, and those of you who work in mental health and substance abuse settings will know these probably much better than I, but in addition to the problems with physical health and mental health that we've talked about and the cognition issues or the ability of the mind to think and perform, they decrease people's social life. There was a very interesting study out of Missouri that actually showed in the emergency room setting in Missouri, people were less likely to have a motor vehicle accident in the 6 hours after they smoked marijuana than people who didn't smoke. And the proposed mechanism was that people who are smoking marijuana are really happy to stay in their room and enjoy the high and not socialize as much or get out. Unfortunately, decreased career status, it's harder to progress in your job if you're having absenteeism and your mind is not functioning well. And so you've got absences and tardies and accidents and workman's comp claims and job turnover. So again, issues important to think about with all of our users, but especially our younger ones. I want to take just a minute to talk about dependence on marijuana, because I think there continues to be a lot of misunderstanding across our society about the fact that marijuana is in fact addictive. You can identify that syndrome fairly simply by identifying people who use compulsively. So they're always thinking about using, thinking about the next time they can use. Number two is loss of control, the people who set limits and say, I won't smoke tomorrow, I won't smoke before a certain time, I won't use in such and such a setting, but they find themselves using. Craving, obviously, again, thinking about, wanting, desiring to use. And then one of the most critical, the last factor, the last of the 4 C's, is the continued use despite adverse consequences. So these are people who have had school problems, family problems, legal problems, relationship problems, and despite of that, continue to use the drug. And it's estimated that about 9% of users actually do become addicted, but those numbers are higher for those who start at early ages, before age 18. So about 17% of those who start at early ages become addicted. A quarter to a half of people who are daily users become addicted, and it's estimated that right now we have about 4.5 million people in the U.S. Who are dependent or abusing marijuana or hashish. What's the withdrawal syndrome? In virtually every drug that we know that causes addiction and dependence, there is a withdrawal syndrome, and it is, in fact, present for those who stop using marijuana and are dependent on it. There's an irritability, a sleeplessness, a decrease in appetite, there's an increase in anxiety, and there's drug craving. It begins within a day, it peaks in 2 to 3 days, and subsides within 1 to 2 weeks. And if you look at this slide, there are a lot of things that are pretty parallel. Probably the common drug that's most similar in terms of the kind of withdrawal syndrome that we see would be something like tobacco or even in some ways caffeine. So these are not life-threatening, medically serious withdrawal symptoms or syndromes, but they are significant, and they do impede many people's ability to stop if and when they make the decision to quit. In terms of treating abuse and dependence, this impacts what we think of in terms of referral to treatment for marijuana misuse. There really are not any helpful pharmacotherapies that have been well demonstrated in randomized controlled trials. But fortunately, medication, again, the symptoms are not severe for most patients. Medication is not needed for the withdrawal syndrome, and you certainly would not use something with addiction potential like a benzodiazepine to get people through their withdrawal from marijuana. What's commonly used for abuse or dependence or cognitive behavioral therapies, contingency management, which is would be a drug treatment program with some kind of incentives, maybe a voucher program for people who are compliant and stay engaged and have negative urines. And then the motivational interviewing has been shown to be effective, and we'll spend some time on that later in the presentation. A handout we find very useful, there's a NIDA infofax for marijuana. If you go to www.drugabuse.gov and look for marijuana, a handout that we find very helpful, especially because we encounter a lot of folks who are early in their marijuana use. They're recreational users, experimenters, They haven't had negative consequences, and so the info facts give us information that can begin to plant seeds that may help them move in the direction of behavior change. So for physicians, it's always been important for us to talk about therapeutic uses, and again, in the age of medical marijuana, I think those of us in the substance abuse field sometimes are stereotyped as being sort of phobic, anti-marijuana folks, and not recognizing that there are some legitimate medical uses for marijuana. And want to acknowledge up front here that these can be effective medical products in certain settings. Number one use, one of the first areas that I'm aware of is the anti-emetic. That means to treat nausea and vomiting. So there are actually two FDA-approved products. One is called Randomized, which is a synthetic THC, also known as Marinol. And then another product, the generic name is Nabilone. The trade name is Sesament. So these are indicated for nausea that's refractory to conventional therapies for nausea and vomiting, and in fact the studies show that they're more effective than the phenothiazines and other commonly used drugs for nausea and vomiting. But unfortunately, the side effects limit their use. And again, if you think back to the pharmacology, you know, these are drugs that have a large effect on the central nervous system. So people get dizzy, or they have a very unpleasant feeling. That's what we mean by dysphoria, but they can be more effective if they're combined with a dopamine antagonist. And I'll just say also when we talk about these drugs, many of the critics of medical marijuana have criticized the fact that there's not a careful control of the dose of the smoked marijuana products, and these two FDA-approved products have been carefully crafted so that you actually know what you get. You're not guessing what's the level of THC and what else might be there for the patient, but in fact they give you the active medical ingredient. Second indication is appetite stimulation and cachexia. So we know that THC stimulates appetite, so the so-called marijuana munchies, and so this is FDA approved for as an appetite stimulant, particularly in HIV wasting syndrome and in cancer. We know the mechanism that pharmacologically it interacts with leptin, ghrelin, and melanocortins to increase appetite. And what you see then is a slight increase in calorie intake and weight gain. The THC then produces weight gain, but again, you have the CNS side effects. So you may get symptoms of intoxication, especially with higher doses. And so the lowest dose, a low dose dronabinol, can help give you this appetite stimulation without the intoxication. And you'll see this through the medical slides here, that again, the doses that you need to get the medical effects oftentimes will give you either the dysphoria or the intoxication, which many true medical users are not interested in. Anticonvulsant effect, if you've watched CNN online lately, has had some programs on medical marijuana, and you may have seen children who had been suffering from severe seizure disorders that had not responded to other therapies responding to THC. And this is, in fact, well documented. THC has an anticonvulsant effect. It can help in children who have not responded to other products. The CB1 receptor, again, that's the central nervous system one, plays a critical role in neuronal firing, and CB1 stimulation has an anticonvulsant effect. Then we've got neurologic and movement disorders different from seizures. The endocannabinoid tone modulates the basal ganglia mediation of spasticity and Parkinson's disease. If you're not a medical person, basically just remember it has to do with spasticity and decreasing that marijuana or THC has the ability to do that. That's a CB2 receptor function. If you use THC, your CB2 receptors are upregulated by about 4 times, and several clinical trials indicate that cannabinoids can decrease spasticity and pain and improve sleep quality in patients with multiple sclerosis. And in one particular study, 90% of patients reported improvement. And then finally, pain relief, and this is maybe one of the most controversial areas, but the CB1 receptor plays a fundamental role in regulating pain behavior. So CB1 agonists, or things that stimulate those receptors, produce analgesia by acting at different places in the neural system, the peripheral nerves, the spinal tracts, the supraspinal tracts. And then the CB2 receptor can play a role in decreasing inflammatory pain. So how good are they and how strong are they? Well, they're similarly potent to codeine. So a lot of our younger folks may not have used codeine. It's not used as much as it was in the past. But codeine is sort of somewhere in the middle ground between something like acetaminophen or Tylenol and a stronger opioid like hydrocodone or oxycodone. So it's a moderate opioid effect. It does produce, again, some dysphoric side effects. But you can combine it with opioids in low doses. And when you use that combination, it increases the pain relief. It can prevent opioid tolerance and also prevent opioid dependence. So there are studies that demonstrate combining opioids and THC. That combination is superior to using the opioids alone in patients with a chronic intractable pain or chronic neuropathic pain. So really interesting data for those of us in the substance abuse area, because we don't really want to use either one of those drugs in the patient that has addiction risk. And to think about using those two drugs together is a little bit scary, but interesting evidence in some of the studies that have been done that you may actually prevent opioid tolerance and prevent dependence. All right, so that's the medical part of marijuana. I'm going to move us then back to the SBIRT process. So we started out talking about using a single question pre-screen, moving from that into using a longer instrument like the DAST, or perhaps the Assist is another instrument you might use, to get an idea of how severe the consequences are and how frequent is the use. So now that you know someone is using, how do you try to help move them in the direction of behavior change toward using less or to stopping completely? So I'm going to talk a little bit about motivational interviewing. It is a collaborative, goal-oriented approach that uses a language of change. That's really the focus. It's intended to strengthen patients' personal motivation to change and promote their commitment to a change goal. Our main job as clinicians is to elicit the patient's own arguments for change. And so if you want to take home one point about MI and you're not that familiar with it, remember that the focus is not what I, as a clinician, think are the risks for the patient about using marijuana. In fact, my job is to elicit any ideas that the patient has, any motivations that they have that might move them in the direction of considering decreasing their use or quitting. The first place that we, as a teaching program, looked was to see, is there really evidence that MI works for people who use marijuana? And the good news is there is evidence. The evidence is fairly new and fairly preliminary, but we'll show you the studies that we found. This is a study by McCambridge and Strang. I believe this was done in Australia in 2004, where there were patients who received an MI-based brief intervention for marijuana use. They compared that with education, which has been a lot of our typical approach, and then followed patients over 3 months. And those who had got the MI intervention reported a 66% reduction in their use of THC. 16% of them were abstinent, and those who got the intervention were 3.5 times more likely to have decided to cut down or quit. 45% of them said they intended to be abstinent by 12 months of follow-up, and 75% reported some kind of higher stage of change than the control group. So very encouraging results. That's the first study we found. This is a study by Dr. Edward Bernstein and colleagues in Boston, where they did a randomized controlled blinded trial of patients receiving MI brief intervention for marijuana use and then followed them up for 12 months. And what they found was twice the rate of abstinence, 4 to 6 days of less use per month, fewer days of getting high, greater efforts to cut back or quit, and patients who are more likely to have received a referral to a community resource. So again, encouraging results from Boston. This is a study from Brazil, from Fernandez and colleagues, and this is actually a telemedicine intervention. It was a toll-free line for people who wanted help. So this is the group that a lot of us wish would come to our treatment settings, the people who want to make a change in their marijuana use. So they did an assessment, a brief motivational interview, and then they mailed reminders, and compared that with an assessment and just setting a target quit date and mailing them some materials. So a problem with the study that only 30% of them completed their 6-month follow-up. So we don't know what happened to the other 70%, but among these 30%, those in the intervention group demonstrated 73% abstinence as compared to about 60% of controls. 16% had reduced their use as opposed to 21% of controls. 2% had relapsed compared to 5% of controls. So in a group that was motivated to begin with and went through the intervention and then made their 6-month follow-up, there seems to be a significant increase in abstinence from use of marijuana. One of the questions that we asked then is we looked at all of these studies and said, what are the effective brief intervention components of these 3 marijuana studies? And so the next slide is, I guess, sorry, I don't have those components here, but they may come up later in the presentation. But they were very classic motivational interviewing components. And so if you learn motivational interviewing, okay, it's the next slide, thanks. The effective brief interventions, the provider developed rapport with the patient, asked permission to address their marijuana use, clarified what the specific substances they were using, provided some brief feedback about their level of risk. In our setting, we call people moderate risk, high risk, and very high risk. We don't like to use the term low risk because we think that gives an unclear message to patients. People did reflective listening, so they actually listened and reflected back to the patient on what they heard. They elicited change talk, sometimes using the decisional balance, which involves good versus not so good reasons for using. And then they explored the patient's values and goals and explored actual versus potential consequences, used the readiness rulers to see how ready people were to make a change, and then explored the motivations for their active level, their current level of change. Then they tried to make a plan, discuss specific aspects of the drug use that they might change, and consider the challenges, how they would confront challenges to change, discuss a menu of options for achieving their goals, and actually develop a change plan. So that's what we saw in the studies that we looked at that showed the positive results that we just shared with you. So a clinical style of MI includes collaboration with patients, again, evoking their thoughts and their motivations toward change, and really honoring patient autonomy. And I know for my own experience, having gone through some fairly, excuse me, classic substance abuse training, pardon me, it took some time for me to reach the point of saying to a patient who's abusing a potentially harmful substance, there's no right or wrong answer here. It's totally up to you, whatever you decide to do. But recognizing that patients will do what they want to do, I think if we recognize that in the clinical setting, it somehow diffuses the client-patient relationship and moves patients in the direction of change. The art of MI does connect the possible behavior change with what the patient cares about, their goals, their aspirations, their dreams, their values and concerns. And in order to evoke those reasons for change, the clinician needs to listen and try to understand the patient's perspective, and then actively elicit any reasons for change that they might have. Underlying assumptions of MI are that ambivalence is normal. And I think for those of us who work with marijuana users, we see lots of them who maybe they don't want to be arrested. Maybe they don't want to have a positive drug screen and get kicked out of school or lose their job or get turned down for a job. But on the other hand, they have things about marijuana that they like and enjoy. It makes them feel good. It's a good recreational experience. It's a great socializing opportunity with their friends. So there are the good and the not so good things about marijuana use. But the change talk is like gold, so that when we begin to hear clients talk about, you know, I really want to have a successful future. I want to graduate from high school or college. I want to get a good job. Those are the things. That's the change talk that's like gold that we want to hear and we want to reflect to patients and we want to summarize as we get on through the interview. It's important to try to recognize different kinds of change talk. Desire would be a statement like, I wish I could cut back. Or ability, I know I can if I desire to. Reasons for change, I want to get my diploma this year. The need to change would be a statement like, I can't lose my job, my family depends on it. Commitment would be a statement like, I've really decided that 2013 is a year that I'm gonna decrease my use or quit. Action would be people who have already taken a step of change. Perhaps they've already decreased their use, limited their use from 7 days to 2 or 3 days per week. Again, taking steps, as people take a step and then outline the next steps that they want to take. Those are all different kinds of change talk that we want to listen for and reflect back to the patient, encourage, affirm, and reinforce. So how do you respond again to change talk? You want to reflect it. You want to reflect back the ideas and concepts and even some of the words that you've heard. Encourage people to elaborate. Say things like, tell me more about that. And then you want to summarize the change talk that you hear. Affirm or support the possibility of change. We know now that many people who stop using unhealthy substances do it successfully with very limited support. So we want to tell patients, a lot of other people have done this successfully. I believe that you can do it too. And then finally, we want to use the ORs. That's our next slide. These are basic MI skills using open questions rather than questions that can be answered by yes or no. You want to use those affirmations that make the patient feel affirmed, make them feel good about themselves and their ability to change. We want to keep reflecting the things that they say, and we want to summarize what we've heard from them, especially the positive things headed in the direction of change. So the MI shift is a very important one. If you're going to use this technique, we move from feeling responsible as therapists or physicians or providers. We're not responsible for changing patients' behavior. Our job becomes that of supporting them in their thinking about changing and in their talking about their own reasons and means for behavior change. Okay, so those are some of the content of the brief intervention for marijuana use. And again, we use the DAST, and we stratify people. Again, people who are occasional recreational users, haven't had much in the way of consequences, we would put in Zone 1. This is an at-risk user, hasn't suffered too much in the way of harm from their use. To get a brief intervention, we ask permission, provide them with feedback, work with some of our MI tools to try to enhance their motivation. We offer some clinical advice based on literature from the alcohol intervention literature that says physician advice, at least, seems to be an important part of effective brief interventions. And then as we move toward the end of the interview, we ask people what might be a next step. We discuss what their next step or steps might be, and really work to close on good terms, affirming the patient, letting them know that whatever they do is up to them, and even if they are not able to complete their plan, they shouldn't consider that a failure, and we'll always love to see them back and help them however we can. So these are the steps. Number one, we ask permission. One of the steps of MI that seems to defuse the substance abuse interview. We tell patients something like, thanks for answering our health questionnaire. Could we take a minute to discuss your results? Could we talk a minute about your marijuana use? Once a patient has given that permission, then we provide them feedback from the Prescreen and from the DAST. We refer to this pyramid. We say, sometimes we'll ask people, would you like to know what your score is and what it means? Well, you scored a 2 or a 3 or a 4. And so that puts you in the risk level that you see here on the pyramid. This may be a place that we give a little brief advice, a little information, tell people that using at this level can be harmful to your health. And really critical, I think, for those of you in the mental health arena is to make any links with symptoms that may have been caused or increased by marijuana use. So if you have people who have anxiety disorders or thought disorders, then there may be a link between their substance use and the problem that brings them to you as a mental health provider. So you want to give that feedback that they've got some risks, some physical health risks and some mental health risks, and this is their score on the instrument, and then we give an opportunity for them to reflect. We ask, what do you make of that? And we set and are silent, and wait to let them process that and share their thoughts about their risk level. Then we spend some time trying to enhance their motivation. We use a decisional balance where we ask people, what are some of the good things about your drug use? And then we ask, what are some of the not so good things about your drug use? The first question, obviously, again, diffuses some of the antagonism that sometimes traditionally we've had in substance abuse treatment, where the patient defends their use as good and we attack their use as not so good. And so this allows the patient to say, well, what I enjoy about marijuana is, and list those things, but also very, very importantly allows them to identify anything in their life that they've found is a not so good thing about their drug use. And once they've given us that information, then we summarize both sides of their thinking. On the one hand, these are the benefits and things you like. On the other hand, these are the things that are not so good for you. The motivational rulers are probably one of the most widely used MI tools, and we find them to be very effective, asking people on a scale of 0 to 10, how important is it for you to cut back or quit using marijuana? And we actually show people a ruler. I don't know that that's necessary. A lot of medical settings use scales now, and so that's a fairly familiar concept. But we allow people to identify where they are. If they're an 8, 9, or 10, then they're at a pretty high level of importance to change. If they're below that, then they may be in moderate levels or in lower levels. But the critical follow-up question when using the scaling rulers is that we ask people, if they're at greater than a 0, why did you pick that number and not a lower one? And if the patient or client understands that language clearly, then they will tell us what has made them as motivated as they are. It may be their school problems. It may be a relationship problem. It may be a legal consideration. But patients will identify the things for us that are already telling them inside that they need to think about changing. And so critical, helpful, very useful tool. How important is it for you to cut back and quit using your drug use on a scale of 0 to 10? And why did you pick that number and not a lower one? And really encourage people to elaborate on that. We can also ask them what is their level of confidence that they can quit if they decided to, what is their level of readiness if they decide to make a change today. If we're not getting much in the way of information, we can ask patients, have you ever considered cutting back or quitting? And if they have, then we ask them why. And again, that will help us elicit their own internal motivations. If there are no past experiences of thinking about quitting, then we may want to ask people what would have to happen for them to consider cutting back or quitting. So always to get into the patient's head and understand more about their motivation toward change. Once we've given the patient a chance to talk about their motivations toward change, then we want to take some time to summarize. And when we summarize, we try to highlight. Our focus is really on the change talk. What did we hear from the decisional balance, from the scaling rulers, that shows any kind of desire, ability, reasons, or need to change, and any steps that the patient might have taken already. We encourage the offering of advice in the medical setting, and if you're a pure practicant of MI, you may know that advice is not commonly encouraged in MI interventions. It is a part of the physician brief intervention literature, and so we continue to use it also with our marijuana interventions, that I as your clinician, I as your provider, I as your physician want to encourage you to think about cutting back or quitting drug use because of the dangers that it represents to your health. For example, you might say something as your physician, I'm concerned about the physical and mental health consequences and the potential effects on your future career. And so I would recommend that you think about moving toward quitting completely. And then ask people, what are your thoughts about that? And again, remembering that there's no wrong answer to those questions. We want to create a dialogue that is non-threatening so that patients who maybe are not ready to change today will feel comfortable coming back and talking in the future about these issues. Okay, I'm going to move. There we go. We try to let people know about some of the risks, the clear risks of drug use that when driving. Marijuana is number 2 and contributing to accidents behind alcohol. When pregnant or considering pregnancy, you've got the risk of a low birth weight infant. If it's contraindicated by some medical condition or medication, and I would think specifically anxiety or disorders and schizophrenic type symptoms, or areas where patients are really playing with fire. And again, if they've had a history of failed attempts to cut back, then those are other people that should think about quitting completely. As we move toward the end of the interview, then we ask people about their next steps. If you were going to make a change, what would be your first step, or sometimes we'll say your next step, and allow patients to identify their own pathway to change. And so we summarize, and finally by closing on good terms. We want to summarize the important content of the interview, emphasize the patient's strength, and again, affirmation, a huge component of motivational interviewing. We want to help people maybe who have struggled a lot, either in their social life, their relationships, and their school performance, want them to see themselves as people with potential and people with a future that they can embrace if they, especially if they successfully change their substance use. We want to highlight their change talk. We want to highlight any previous changes in behavior that they've made. If they, for example, have stopped smoking or stopped drinking or changed some other behavior, maybe they started exercising regularly or lost weight, those would be patient strengths that would point toward their ability to change this behavior. We highlight their change talk, their desires, and their reasons, motivations toward change. We list, review decisions that were made regarding next step, and then we arrange for follow-up as appropriate. And wherever possible in the primary care setting, we certainly want to encourage people to come back so that we can continue this dialogue. So the next slide, let's see, I went over it. We actually have video clips that we were not able to show for the webinar today, but if you go to our website, www.sbirtonline.org, you will see interviews. They're relatively brief interviews in the 5 to 10 minute range for at-risk marijuana users. And so our first user is a young lady who's used recreationally, and she's had some dysphoria. She had a kind of an anxiety, almost a panic reaction using marijuana. And so she was already beginning to think about changing, and in this conversation she makes the decision to stop using, and we sort of think through what will she do in the future. Will she continue to go out with her friends who smoke? And if she's offered marijuana, how would she respond? So that's the first video. And in addition, on the website, you'll find role-play materials. If you're in a teaching setting or you want to practice, there's actually some screening material from a similar case, but a little bit different, that you can use in practice role-plays with yourself or with others that you are teaching or training or work with. I'm going to skip that slide and just talk briefly about dealing with time pressure. And maybe most of you are not in primary care, so this is not an issue. But in primary care, all of our physicians want to say, well, I don't have much time. I have other things I need to talk about. And rare that patients come into primary care wanting to talk about their marijuana use. And so we try to do pieces of the brief intervention over multiple visits. At the first visit, we can just use a minute to cover the first few steps. Could we talk for a minute about your marijuana use? Based on your questionnaire data, it looks like you're at this level of risk related to your marijuana use. I'd like to encourage you to think about cutting back or quitting. Could I share this pamphlet with you and give them the NIDA info facts, and perhaps we can talk about your marijuana use at a future visit. So that's a real quick way that in primary care we can make an initial brief intervention with patients who are using marijuana. So again, ask that permission, provide feedback on their risk level, offer them advice to quit or reduce, give them the patient education material, and invite them to discuss this at a future visit. Now, remembering that investing a few minutes early may prevent some potentially serious consequences in the future. Well, what do we do with the higher risk patient, or the patient who may be dependent, the patient who's got severe consequences? Again, these are people with scores 3 or 4 or more on the DAST. The approach is very similar to what I just showed you, but there are some slight modifications, and I'll show you what those are. The first is that we emphasize abstinence. If we're beginning to see major life problems related to marijuana use, and we're going to talk more seriously with the patient about considering abstinence as a goal rather than simply cutting back. And in our initial conversations with people about marijuana, alcohol, and many other drugs, many of them will say to us, well, I'm not really at a point where I'm ready to quit yet, but I would I'd be willing to think about cutting back. And as practitioners of motivational interviewing, then we follow the patient's lead, and we go down that pathway. We encourage them. We try to help them make plans for cutting back. But for the patient who's experiencing significant consequences, at some point when we talk about our brief advice, we say, well, you know, as your physician, as your clinician, as your mental health provider, I have to tell you, you know, from my point of view, the best thing for you would be to quit and quit completely. What are your thoughts about that? But if patients are not ready, then we move on and work with them at the level of change that they are willing to make, knowing that we can anticipate, in most cases, some harm reduction if they will at least decrease their use. We also assess the withdrawal risk. This is not as big an issue with marijuana as with some other substances, but we ask people, we try to discern if they don't use, do they have symptoms, and we make a plan for dealing with those. And then we ask for permission to let people know what other resources are available for interested patients, and we actually give them information about if they're ready for higher levels of treatment, where they might go. So again, we do the brief intervention. We raise the subject by asking permission. We give them feedback. We use those motivational interviewing techniques to motivate and elicit change talk. When we offer that advice, we emphasize abstinence. When we discuss the next steps of the plan, if the patient is open or ready at all, we offer them a menu of additional resources. And often we'll begin that with a statement such as, could I share with you some resources that have helped some of my other patients who've had similar issues to you in their marijuana use. We assess and address possible withdrawal risk, and then we close on good terms. This is just some ways that we talk about withdrawal assessment. Some people get sick after a day or two without using. If you had any of these symptoms, you get irritable, sleepless, you get cramps, your appetite decreases, you have anxiety, you crave drugs. And so again, usually we don't use medications for these, but we might talk about ways that they can manage these symptoms to get through the first few days without marijuana. Medical treatment not indicated. Again, you especially want to use avoid using benzodiazepines or potentially addicting drugs. What's a menu of options? What other things can we offer people who use marijuana? There's not really any current pharmacotherapy for marijuana addiction or marijuana dependence, but we can encourage people to use self-help or support groups like NA, AA, Celebrate Recovery. We have in-house counseling that provides brief treatment using MI approaches in our area. And then there are numerous treatment programs in our area. For the most part, for adults, you'll be talking about outpatient treatment. Occasionally with adolescents, you might be talking about inpatient treatment for a time. I'm going to skip this slide in the interest of time. Just in ways that you might enhance your interventions. We really encourage our providers to resist the urge to fix the patient at the very first visit. If patients are not ready to change, then that behavior change is more likely to start with our planting the seeds, using MI techniques, and giving the patient an opportunity to process their own motivation toward change, rather than ours, than us hammering away at them and trying to force them to make a commitment they're not ready to make. So we focus a lot on building rapport, that client-patient relationship. Obviously, we don't want to do any kind of labeling, any kind of judgmental statements or attitudes. I think the words are probably rarely used, but the attitudes many times patients can pick up on if we're judgmental toward them. And again, we want to encourage their self-efficacy, especially highlighting any past changes in behavior that they've made, saying, look at the successes you've had in the past. I really believe you can do this. We do have another video. I won't show it again today, but we have another patient at a higher level of use who's already lost a job. He's having some issues in his home. His wife is concerned about him using and the impact on their children. And so we work with him about making the decision to stop and discuss with him different avenues that he might take toward treatment. In our setting, we do try to document what we do. I guess that's part of healthcare in 2013. So we try to list the DAST score and the risk zone, at least comment that a brief intervention was done, describe the patient's response or plan, and then we need to document the duration for billing purposes. And then in terms of coding options, these are the ICD codes that we use for cannabis abuse, cannabis dependence. And then for SBIRT services, those are potentially reimbursable. We use the codes at the bottom, the V codes. We like V65.42, which is counseling on substance use and abuse. And then the next slide will tell you you can bill for 15 to 30 minutes of SBIRT if you're a physician, nurse practitioner, LCSW, clinical nurse specialist, a psychologist, or a PA with a license to practice, and you can file for 15 to 30 minutes or greater than 30 minutes using the different codes for private insurance, Medicare, and in many states, Medicaid. So in summary, marijuana use carries significant medical and psychological risks, and the clinical trials suggest that MI is effective for marijuana users. SBIRT systems can facilitate identifying patients who are in early phases of misuse, as well as those who may be dependent on marijuana, and effective clinicians will invest time in eliciting and enhancing patients' reasons for considering making a change that will improve their health. Finally, referral to higher levels of services is available for those who need more intensive treatment. And if you'd like any of the information that you've seen today, some of the things that I mentioned, please take advantage of the information that's at sbirtonline.org. You can find this PowerPoint and module if you want to use it to teach. You'll find the intervention card, the videos, some role-play scripts, and the DAST instruments. A few references for those who are so inclined. If you want to do a little more reading on marijuana, those are there. And at that point, I'm going to slow down and take some questions, and thank Tracy. I think you're going to moderate the Q&A session. I want to ask Denise Clark, MFT, who's done actually a lot more clinical work than I have dealing with patients with brief interventions, to join me as we, Denise, if you want to step in the room with me, we'll work back and forth with the phone here and take people's questions. Tracy, what kind of questions do we have?
Great. Well, thank you, Dr. Seal. Really appreciate the webinar content you've just shared with everybody. It's really exciting to see your protocols, and we've got a lot of interest in this topic, to say the least. So let me see if I can find a couple of questions for you here. Let's see. We have the first question is, does casual use of marijuana qualify as drug abuse?
Great question, and I would say clinically doesn't meet criteria for abuse. We use the DSM criteria for abuse, so under the DSM criteria, you have to have recurrent negative consequences in at least one area of your life over a 12-month period of time. So, for example, a patient have never had any consequences would not meet criteria for drug abuse. On the other hand, if they get a driving citation, get kicked out of school, they have a boyfriend or a girlfriend that breaks up with them over their use, they have a parent that kicks them out of the house, et cetera, if they've had repeated consequences, so if they've had 2 incidents over the period of a year, then they would meet criteria for substance abuse.
Great. Thank you so much. And our second question is, and I think this is interesting because I'm beginning to get these kinds of questions now when I do presentations on SBIRT with risky alcohol use. And so it'll be interesting to see what your thoughts are. Now that with the DSM-5 and removing legal aspects to the criteria, how do you know whether the screening tools like the DAST-10 will be revised or will we be moving to different types of screening tools?
And I'd have to answer that with a great big I don't know. I think we're going to have to hang on and see what happens as DSM has implemented. The major change that I'm aware of, and I have to say I haven't studied the DSM-5, but we're going to lose substance abuse as a criterion. It's going to be different levels of substance dependence, and so it's sort of all gets lumped into one, and what we might have thought as abuse, my understanding would be considered a lower level of substance use disorder. I don't think it's called dependence anymore. So I don't really see our treatment approaches changing significantly. Our documentation will have to change, and I understand that we're going to face major changes in documentation with ICD-10 as well. So it's just going to be another part of the change in our healthcare system. But I think the approaches that we use will probably remain fairly similar. How we document that and how we bill for it will be different, and we just have to pay attention to what diagnoses we're supposed to use. And there may be some new instruments. If there are certain documentation requirements that are required for billing, then we may see some different assessment instruments. I don't know. We'll have to wait and see how that evolves.
Right. Yes, and that's often my response as well. I think things are ever changing right now. We just have to keep our eyes and our ears open. The next question I have is, does the morbidity/effects of marijuana differ between smoking and eating it?
Oh, great question. I think the main difference you'll see would be the pulmonary effects. So I talked about the main medical effect being pulmonary. So you get this chronic cough and secretions and more respiratory infections and so forth. So obviously if you eat marijuana or you take the drugs, then you're not going to have those pulmonary effects. So I guess, yeah, that's one medical benefit of going from smoking marijuana to another route of administration, but probably most of the other effects are going to remain the same.
Great, thank you. And do you have a recommendation on a resource list with the research on the effects of marijuana that you've been discussing?
We really started with the NIDA InfoFacts, and they've actually changed the website and the content of that. But that's where I go. I feel like NIDA is a research institute, whereas if you look at materials that might have come from other government agencies like, I don't know, the Office of National Drug Control Policy, or some other sources that may have a kind of an agenda to try to bias information in one way or another. I feel like NIDA has been pretty good to try to stay research-focused and balanced in their approach. So that's usually where I start, and then the references, obviously, that we had at the end of the webinar. But I'd start with the NIDA InfoFacts. I think they're pretty balanced.
Great, thank you. Let's see, we have a couple more minutes here. Is the DAST-10, this person says, in the DAST-10, I believe I saw a question about combining drugs. Does this just mean that combining illegal substances or those used without a prescription?
Let me pull that up again. I was going to make a comment about assessment instruments because we've worked in a couple of different settings, and I didn't spend much time on the assist. But we have health education specialists who do motivational interviewing in our hospital, and they have a longer time to do assessments and interviews, and they really like the assist. I think I didn't mention that. It's a more lengthy instrument. It gives you more information. And they're working on validating a shorter version of that. So we're going to see a condensed assist, I think, sometime in the next couple of years. So there are other instruments out there that may be better. We quite honestly picked this one because we work in clinical settings where time is of the essence. I'm sorry, I've got really small print here, and I can't. I'm going to have to pass on that question. I don't remember there being a question about combining drug use, but it could be there.
Okay, great, no problem. We have a question about how would you handle people with both alcohol and marijuana abuse?
Well, as a practitioner of there are a couple of different directions that I might approach it. Typically in motivational interviewing, we will start with the patient's agenda. So what is most important to them? And that's been some frustration to us in the hospital setting because we may be real concerned about a drug problem or an alcohol problem. The patient wants to focus on their smoking. But we follow the patient's lead. And I, as a physician in the advice portion, my other agenda item is to identify what seems to be a major health risk. So, for example, if I had a patient who's using alcohol and marijuana and they choose to work on their marijuana, the medical consequences of alcohol oftentimes are much more severe. And so I might point those out. We might then take the patient's lead and work on their marijuana, and I might add in my education/advice part of the interview, say, as your physician, I want to encourage you to think about at some point dealing with your alcohol use as well, because you're starting to show some liver damage or whatever the concern is. But typically we'll allow the patients to start where they're ready to change, and we found that to be more successful. And a surprising number of times people, once they start to make behavior changes, they keep going in the direction of health, and that's very gratifying.
Mm-hmm. Great, thank you. And how do you get your family medicine doctors to take the time to learn some of the motivational interviewing strategies that you shared with us today? Is there a carrot that gets their interest?
I would say the carrot is the reward of trying these techniques and seeing them begin to pay off. And we find, there's a subgroup of physicians who really like this and enjoy it and gravitate toward. There's another subgroup that is kind of allergic to it and doesn't want to try it. And for those folks, we try to get them just to begin to experiment with some simple techniques and to taste the fact that of how much it defuses the doctor-patient relationship, and the fact that they oftentimes will begin to see small steps in the direction of change. So we've made it a part of our regular curriculum. Our residents get a 3-hour seminar on motivational interviewing as a part of their behavioral science training here, and then we try to reinforce that. The other thing that we do, Tracy, is we try to show applications in other areas, and you can use motivational interviewing to work on weight loss, on exercise, on medication adherence. And so one of our newer initiatives has been to develop teaching sessions where we don't even talk about alcohol, drugs, or tobacco. We talk about those other issues, and we find our docs are really, really interested in techniques to help with that frustrating patient who won't take their medicine. So that's another kind of carrot, I guess, that we've used. And Denise Clark, who's with me today, has done that and done it. We have a session coming up soon that's devoted just to examples like that.
Great, thank you. Let me see if there are any other questions. Are the videos that you were mentioning, are those available? I know they're large files. Have they been migrated to the web? Is there a link we might be able to share with our attendees?
Yes, if you go to SBIRTonline.org, one of the tabs across the top is videos. So you can go from that directly to the videos, and they're actually posted on YouTube. So those are easily accessible on the web, and you'll find interviews for both alcohol and marijuana, as well as some interviews about pain and opioid abuse.
Great. Well, that's terrific. We can post that URL with along where we've already posted the PowerPoint slides that you generously shared with us, and the intervention cards, which are also already available online. And so I think we're right at the hour, and so I think we're going to close the question session, if that's okay with you, Dr. Seal.
That's great.
Okay. Well, I again want to thank you very much for for giving this presentation. Certainly this has been a much requested topic, and it's nice to have an expert like yourself who's really working in the real application of this in real-world settings, talking to us and sharing what you're doing. I want to just thank also all of the attendees who have joined us today and their terrific questions. Again, we can try to get some of these answered perhaps as a follow-up. Please email me directly. You have my email address, which is on the slides that you've already downloaded. And I also want just to say to our attendees that, again, we really appreciate you completing the evaluation form that we'll be emailing you. It's really critical to understanding what's working and what you really value in the kind of information that we're sharing with you. And also to remind you to look out for an email that have a link to the well, actually have information on how to get your certificate of completion from IRETA and also continuing education credits. So thank you again for joining us. And this, again, will be posted and archived for your availability in the future as a recorded session.
Thank you, Tracy. Great to be with you. My pleasure.
Thank you, Dr. Seal.